you so much, and it is just wonderful to be here, and I want to thank Ovarian Cancer Australia for the opportunity. I'm here for the whole conference across the road here, but I did take the opportunity to be here from early this morning, and I've really enjoyed the day, have found it great updates, listening to international speakers on the latest research, and I'm a professional in the area, but I've learnt so much this morning, and have really enjoyed the opportunity to meet and talk with some of you over the breaks as well. So we are going to change pace a little bit in this next session, in that instead of talking about, I suppose, the latest updates in treatment and screening and the like, we're actually going to talk about the latest updates in how we can build wellness and health and well-being and quality of life. So I think that this is a particularly important session in a program like this, and I know that we have got, again, some of the leaders in research and practice in this area. Interestingly, though, when I was saying that, they're all actually Australian, so it's really nice to know that our Australian researchers are some of the leaders in research in this area in terms of building wellness and quality of life. So I'm going to head straight into introducing our first speaker, and just note we'll have Professor Michael Friedlander speak, and we'll take questions, and then we've got a panel of speakers, and we'll have plenty of time for questions after that. So please do, we'll give a chance to address questions to Michael first up, but in the panel we'll get you to hold your questions until the end. And there's plenty of time, despite the fact we're running late. I'm sure we'll have plenty of time for discussion. So firstly, let me introduce Professor Michael Friedlander, who's clearly a leader in gynecological oncology. Professor Friedlander is a conjoint professor of medicine at the University of New South Wales and senior staff specialist in medical oncology at the Prince of Wales Hospital and the Royal Hospital for Women in Sydney. He's been involved with both national and international level in the field of gynecological oncology for the last 30 years, and has been closely associated with IGCS since it was established, to the extent that he was president of IGCS from 2004 to 2008, and has received an IGCS Award for Excellence in Gynecological Oncology just a couple of years ago. So we're very privileged to have Michael talk to us about short and longer term effects of treatment. Thank you very much.
Good afternoon, and thank you very much for the invitation. And I'm going to talk about, I guess it's the double-edged sword, the benefits of treatment as well as the downsides, and in particular, recognising the downsides of treatment, both the acute toxicities, acute side effects that occur during treatment, as well as the potential late effects of therapy, and what can we do to reduce the burden. And there are a significant number and an increasing number of survivors of cancer treatment, and in particular in ovarian cancer. And just the United States alone has recognised that in a recent publication there are almost 200,000 women who are living in the United States at the moment who have been treated for ovarian cancer, and that's increasing, and clearly there's a large number of women in Australia as well. So what I'm going to be talking about are the treatment-related side effects. I'll discuss the variation between clinical, the medical assessment of side effects, which is traditionally the way we've measured toxicity or side effects in clinical trials, and the discordance, if you like, or the difference between patient assessment of their own side effects and how doctors or nurses are scoring these side effects. This is very important, and clearly, to me at least, patient-reported side effects mean a lot more than clinician-reported side effects. I'm going to focus quite a bit on Taxol or paclitaxel and its effect on nerves, because this is a very important side effect. It often persists. It can have a very negative effect on quality of life, and detecting it early is critical, and we still have a long way to go before we can prevent it. I'll then discuss some of the late effects of treatment, and these are late effects not only of chemotherapy but also of surgery, radiation and the like. And then I'm going to move on to follow-up studies. What do we actually know about the burden that women who've been treated with ovarian cancer? I'm focusing on ovarian cancer, but this does apply to all the other gynecological cancers as well. And then discuss, at the very end, some current areas of research that ANSGOG are leading at the moment. So when you look at the side effects of treatment, it's complicated because you've got a mix of treatment-related side effects, treatment-related to surgery, often premature menopause and the menopausal side effects in someone who was still menstruating prior to the diagnosis of treatment. There are multiple contributing factors depending on just how well the person was before they went on to treatment and what other medical conditions they had. And with respect to chemotherapy, it depends on what chemotherapy was given, how the chemotherapy was given, where the chemotherapy was given, in other words, directly into the abdominal cavity or the peritoneal cavity, where the side effects are quite different. The schedule of chemotherapy, there's very different side effects to give the treatment once a week as opposed to every 3 weeks, how long the treatment went on for, and whether people got what's called maintenance therapy. In other words, stayed on treatment, be it chemotherapy or some of these new targeted therapies you heard about earlier today. And all these things impact on the side effects and on survivorship. And of course, then it's made even more complex because it depends on when the treatment's given. Is it when someone's first diagnosed with ovarian cancer or for recurrent cancer? And how many lines of chemotherapy? Because a lot of these side effects are cumulative. So it's very difficult for me to give you a sort of a one answer or a take-home message because it really is complicated and needs to be individualized and personalized for each patient in terms of how we manage them. In addition, there's further surgeries, often radiation, and there are a lot of side effects with the new so-called targeted therapies. Now, targeted sounds really good, and they are good, but there are many off-target side effects. So there's a lot of collateral damage. These are not smart bombs. There's a lot of damage that occurs, and learning how to deal with those side effects has become increasingly important because most oncologists, medical oncologists, have got very used to and pretty good at treating the side effects associated with chemotherapy. But when we move into this whole new era of so-called targeted therapies, it's a whole range of new side effects, all of which have to be managed differently and very, very different to this traditional standard side effects that we've grown up and had been taught how to use. And then finally, the age of the person makes a difference with respect to side effects and what pre-existing medical conditions they had. And this just shows you how complicated it is. If you just look at the side effects of therapy, and this won't come as a surprise to anyone who's had chemotherapy, particularly anyone who's had carboplatin and Taxol, which is the kind of soup du jour of gynecological cancer. There's not too much else on the menu, but there are a few other things. So the side effects are listed, and they include, as you all well know, nausea and vomiting, fatigue, hair loss, alopecia, which most people will get, muscular aches and pains, constipation. Constipation actually tends to be more a problem with the anti-nauseants we use rather than the chemotherapy itself. But it can be a real problem. It can be oftentimes the most important problem, and picking it up early is critical. Numbness, peripheral neuropathy, really, really important because if it's not picked up early, and if there are not some changes or amendments or reductions in doses, you can end up, as I'm sure many of you in the audience appreciate, with permanent numbness. And that can have a really negative effect. And if you're treating someone who has pre-existing problems, they may have mild Parkinson's or they may have some balance problems, and once you have a peripheral neuropathy, you can imagine the increased risk of falls, etc. So these are all really important, low blood counts, etc. Now, there are some things that we can treat quite well, and there are some things that we are not so great at. And one of the ways that we try and assess toxicities in clinical trials, in particular, as well as in the clinic, is the clinicians ask patients what are the side effects, and then the clinician scores these side effects. Now, you can imagine that quite a lot can be lost in interpretation, and there is a discordance or a difference in many times between what the patient actually scores as the most important side effect and how much that toxicity or side effect is affecting her compared to what clinicians say. So sometimes clinicians underestimate and sometimes they overestimate, and sometimes there's an agreement. But I think the recognition is increasing recognition that we have to include patient-reported toxicity or side effects in clinical trials, and I think in the clinic as well, because that's really what counts. And so in some of the trials, patients have reported much greater symptoms such as pain and constipation and shortness of breath that you would actually get when you look at clinician scoring. I won't go through this in detail because it's a complicated slide, only really to point out and to mention that the side effects increase over time, as once again I'm sure most people in the audience will appreciate. And they are cumulative, so therefore keeping track what's happening with each cycle of treatment is really, really important, because some of these things you can try and nip in the bud, or perhaps say drop the Taxol dose or lower the Taxol dose if someone has significant numbness. So this just shows you one trial or one study that was done out of Germany looking at the level of agreement between what doctors thought and what patients thought about their side effects. And you can see that there definitely is a degree of agreement, but there can be quite a lot of differences with respect to nausea and pain and constipation, shortness of breath between what doctors think and what patients think. So just going back to the fact of asking patients. Now there's certain things that we can do something about, and there are other things we can't. So nausea and vomiting, we can generally make a difference. Now we can't prevent nausea and vomiting in everyone, but I can tell you, because I've been doing this for a very long time, that when we first started treating people with chemotherapy, and this was with cisplatin and cyclophosphamide, I'm talking back now in the 70s and very early 80s, it was a nightmare. We had very poor anti-nauseants. We used to admit everyone to hospital to give cisplatin. The only drug we had, we had Maxilon and we had steroids, but it didn't work most of the time. It didn't work very well. And we used to use Ativan or lorazepam. And we would bomb people out, and they would come in and they would get 5 milligrams. And I think about it, I shudder. We used to give a big dose of Ativan, which basically made people forget how bad it was. There was all this, it's true. There was this what's called retrograde amnesia. So I'd go around the ward in the evening before I left, and there may be 10 people fast asleep. I used to phone up every couple of hours to make sure they were still breathing, because I was so worried. And you could just hear the vomiting. It was awful, absolutely awful. And in the morning when I went around, as I read the nurse's notes, and most people had a really terrible night and were vomiting, and it was just awful, but they didn't remember. And that was as good as it was. So you've got to think back how bad things really were and compare it to now, because we very rarely would admit someone to hospital for chemotherapy, certainly not the chemotherapy we usually use to treat ovarian cancer. And although I'm sure people in the audience have vomited, it's actually not that common. Nausea is in some people, and if you are smart about using the anti-nausea drugs properly, you can usually control it in most people. As well as preempting the constipation, the low white cell count, we can do something about, although it's very difficult to do in the Australian context because we don't have access to white cell growth factors. They're not approved, so they're very expensive. Anemia, clearly we can do something about, and that's with transfusions. Fatigue, I think we can do something about fatigue. Fatigue is very complex, and you're going to hear more in a moment about exercise and how important exercise is in reducing a lot of these symptoms and toxicities, and we can certainly introduce exercise into treatment very early, and Sandy will tell you some really interesting work that she's doing. Peripheral neuropathy, we do not have a good way of preventing at the moment. Insomnia is a really, really common symptom. About 40% or 45% of people complain of inability of sleeping, and it is complicated, but there are probably things we can do about that. And similarly with mood disturbance. We know that maybe between 25 and 30% of women have clinical depression or significant anxiety. This is often not detected. People don't report it, and we don't often ask the right questions, and we don't screen for it properly. But it is amenable to treatment. You can do something about it. I think exercise probably makes a big difference for mood disturbance and insomnia as well. So exercise is cheap, but it takes some effort, but it's really good. So the side effects depend a lot on how we give the treatment. Now, intraperitoneal chemotherapy, or IP chemotherapy, is associated with a lot more side effects than the intravenous chemotherapy. In fact, the side effects were so great that only 40% of people could actually complete 6 cycles of treatment, and the treatment was stopped because the side effects were unmanageable. There was an improvement in what's called progression-free survival and also some survival advantage with the intraperitoneal treatment, but this never really took off internationally, mainly because of the side effects associated with treatment. And around the time that all this IP chemotherapy came about, and there was a survival difference, another trial was reported out of Japan, where they did something very, very simple. And that was, instead of giving the chemotherapy like we always do, once every 3 weeks, they gave the Taxol chemotherapy every week. So the same dose, but it was divided into 3 weekly doses as opposed to once every 3 weeks. And what the Japanese trial showed was very, very similar results to the IP chemotherapy. Now, IP chemotherapy is where you give the Taxol into the peritoneal cavity as well as the platinum into the intraperitoneal cavity. So, and you give you give the Taxol on day 1 when you give the platinum, and 1 week later, then you have a week off and you start again. And we sort of began to think maybe this was just a much more complicated way of giving what's called dose-dense chemotherapy, the way the Japanese were doing it. So that sort of took over, and we still use IP a bit, but not as much because the Japanese trial was so much easier to give, and the results looked much the same. Now, we'll know very soon whether, in fact, the results of the Japanese trial of weekly treatment will be as effective in Caucasian women. It's a really important question because it may be it's something specific to Japanese women, because we know that the side effects can be very different in Japan. We know that certain drugs are metabolized very differently in different ethnic groups due to the way they inherit various enzymes or changes in enzymes. So we just don't know for sure. But there is more side effects, or some increased side effects with weekly treatment. Anemia is very common, so we often have to transfuse women to reduce the side effects. But things like neuropathy or numbness isn't any different. So that is, I guess, what's more commonly used around Australia, but it's quite intensive. It's coming in every week, it's tiring, and there's a lot more anemia associated. Now, more recently, as you know, Avastin or bevacizumab has been used, incorporated into the treatment of women with ovarian cancer. I've got 5 minutes to go? Oh, then I better move on. This has brought us a whole new raft of side effects, which I won't go into great. Now, I'm going to move on to neuropathy because it's really important. There's numbness, there's tingling, there's burning, and there's cold-induced pain. And because of time, I'm going to move on. But we do need to be very careful when we select people for treatment that they do not have pre-existing numbness or anything that may increase it, like diabetes, because those people are much more likely to have problems. And also occupation is really important. So if I see someone who's a concert pianist or plays the violin, and you don't want to be using paclitaxel if you can avoid it, because you can be sure it'll interfere with their ability to function afterwards. I'm going to move on because I didn't realize I had 5 minutes. I was sort of rattling on there, but sorry. But I want to talk about late effects because I think that's particularly important. And this was an important article written by a physician in the early 1980s. And this was before anyone really paid much attention to survivorship and the survivorship issues. And he published this in 1985 as a letter or reflections of a physician with cancer. And he said, "It is as if we have invented sophisticated techniques to save people from drowning, but once they've been pulled from the water, we leave them on the dock to cough and splutter on their own in the belief that we've done all we can." And this was, I guess, the birth of the focus on survivorship, but it took a long, long time before it got through. And there are many late effects, and generally our clinical trials have not captured these late effects. we have focused on what are called progression-free survival and overall survival, and the late effects are often not detected, not picked up, and no one really knows much about it, and there's very limited data on this. I mean, it's hard to believe, but it's the truth. Now, there's one small survey that was done by a colleague of mine where she sent a questionnaire out to about 100 women who had been treated with ovarian cancer. And I saw this a couple of years ago and I knew about it, and it sounded really interesting because they found that there were a significant number of people who were complaining of, this is after they completed treatment, way after sometimes, tiredness, emotional disturbance, hot flushes, insomnia, weakness, numbness, everything you care to imagine. And they were just out there in the community. And their doctors weren't aware of it or weren't detecting it, because when they looked at what the clinicians had documented in their letters and saying, Mrs. Jones is feeling great and there's no problems, but when they looked at what Mrs. Jones actually was going through, there were lots of problems. So this got us to thinking that we need to look at this in a lot more detail. And in fact, as I said, there have been some studies, but not a lot, and there's clearly a high prevalence of fear of recurrence, a lot of sexual issues, there's fatigue, anxiety, greater use of health services, greater use of medications. But there are some people who do have good quality of life, not everybody. So what else do we need to do? So this gets on to what we're doing at the present time, and that's trying to what we call embed survivorship endpoints into our clinical trials. So looking at long-term quality of life, using patient-reported side effects rather than clinician, and looking at what we can do in terms of interventions. So 2 studies that we're currently doing. One is called the MOST Opal trial, and this is trying to detect and understand what the long-term effects of treatment are. So MOST Opal, as some of you might know, is looking at the impact of lifestyle on outcomes in women with ovarian cancer, and we are asking questions every 3 months out to 2 years and now out to 3 years about the side effects that people are suffering and what they're going through. And OviQuest, which I will encourage you to all be involved with if you haven't already, is an online questionnaire, and it's living out the diagnosis and treatment of ovarian cancer. We ask a whole lot of questions regarding side effects, sleep, physical activity, etc. I've seen it, I won't be long. And the key messages that have come out of it so far is that there's a significant symptom burden after ovarian cancer, and things don't necessarily get better over time, and most people want to share their experiences. And I won't go through the various quotes, but this is just one example. 2 years into my cancer experience, I'm exhausted, overwhelmed, and ready to give up. So we are recruiting patients now for this study in Australia, New Zealand, the UK, US, Canada, and Germany. And we've recruited about 900 women so far, and we hope to get to quite a few thousand. And this will help us then get grants from the government to try and address these questions. So if you haven't filled out the questionnaire, please go to the website, and that's me done. You'll be pleased to know. Okay, thank you very much.
Get Michael to answer a few questions. Michael, I was one of those nurses in the early 80s.
You remember?
I do, gynae oncology ward at Mater Hospital in Brisbane, and I absolutely remember it was bringing back those days. And I think some of the important things that I got from your talk there was that we do today have a bit of a different profile of some of the experiences that women are having, and some of those we deal with pretty well, especially if we pick them up early, and some of them we're still learning about how to deal with them. And I think the other thing that we're much more aware of now is that these effects are not just during treatment, but that people can live with them for a long time, and I think those are really important messages. The other key thing, I think, is about the patient-reported stuff, and how part of this is actually still a little bit hidden, and how important it is that people are able to talk. But let's take questions from the audience. There's one at the back there.
Have there been any recorded instances of acute abdominal pain, even several years after the use of things like paclitaxel and cisplatin?
No. I see one of the problems also is trying to separate things that happen generally. I mean, because people can get pain for all reasons, and this is the big problem when you're following people up, to recognise that there are side effects of treatment for sure. There are symptoms of recurrence, which can be mistaken for side effects of treatment or late side effects. And then there are things that just happen because they happen. So you're going to get flu irrespective of whether you had chemotherapy and headaches, etc. So acute abdominal pain is not related to Taxol or platinum years later, but it could be related to the treatment, the surgery in particular, with adhesions and bowel obstruction. And we often see this very commonly around this time of the year. December, in particular, over Christmas, when people eat lots of nuts and mangoes because of high fibre. Because high fibre and adhesions, and you get a lot of cramping pain. We always admit about 3 or 4 people around Christmas with subacute bowel obstruction secondary to high fibre.
Did mango farmers any good? Question down the front.
So, Jane Fletcher, I'm the psycho-oncologist on the program. The underreporting of symptoms, I think, is for everyone in the audience, for all of those women to remember that to tell their clinician if they have an issue and to keep talking about it, to keep bringing it up, because I think things fall off the agenda in sessions because you address the most important issues and then some things fall off the agenda like sleep, and it can have a huge impact on quality of life. So to keep bringing things up.
So that's why we've actually developed a new instrument which we're currently validating, which we hope will be used in clinical practice, and it's called the MOSE, the Measure of Ovarian Cancer Symptoms and Treatment Concerns. And what we hope, and this is what I didn't, because of time and that thing waving, I didn't go into it in detail. I started to panic. What we hope we're able to do in the study is actually use this as an aid memoir, so women can bring this to the clinic every time they come, because often you get lost in focusing on 1 or 2 things, and we can track that over time and address the issues that are in the instrument.
Sorry, well, actually, we'll probably just take this lady here, then we'll come to you.
I'd like to know how you grade peripheral neuropathy, and when should you be worried about the symptoms being too much?
Yeah, look, I think it's a really good question because, you know, when you grade peripheral neuropathy, it's very subjective. You can't measure it. So this is dependent on what the person tells you. And one of the problems, I think, is that it depends on the eye of the beholder, and it depends what you do. So a mild peripheral neuropathy, mild for someone, may be very severe to a concert pianist. So grade 1, just some minor pins and needles, if you like, that do not interfere with function, may be acceptable to many people, but unacceptable to others. So I think it depends on the context in which it occurs. Now, one of the difficulties we have, and this is always this challenge we've got, about making dose reductions or dropping treatment, where you may be potentially compromising the benefit of treatment or the activity or how effective the treatment is with the side effects of therapy. So what they found, for example, in the Japanese trial, when they were giving the weekly chemotherapy, was as long as you sort of stayed above 70% of the dose, you didn't seem to lose benefit. But once you dropped too low, then there was a potential to lose benefit. But I think it's a balance, and this has to be discussed with each individual. But what you don't want is to end up with functional issues, can't do your buttons, can't walk properly, falling. I mean, that, I think, is unacceptable to most people.
One last question over here.
I love the idea of the patient-reported outcomes being part of trials. How far do you think we are from them being a standard part of trials? And then the second part to that is, how far are they from being a way in which decision makers judge what drugs to approve for funding?
This is like Dorothy Dix, because this is my passion. and I think we're getting there. We have just almost completed a very, very large trial. It's an international study which I've been working on with many other people, but for the last 7 years. It's called the Symptom Benefit Study. This is for women with platinum-resistant ovarian cancer. where we've been trying to develop better ways of measuring benefit rather than looking at CA125s or CT scans, because really measuring benefit is making people feel better. And most people don't feel much better if their CA125 falls. They might, but they may not. So I think that there is increasing recognition about the importance. One of the problems is the regulatory agencies pay lip service to this. They say it's important, and they have guidance documents to say it's important. But when they actually approve drugs, they don't actually use it. Not certainly yet so far in ovarian or gynecological cancers, but they have. There's a major push to see this happening. And we're now recognising that what's happened in the past is when quality of life was included in clinical trials, I think it was there for political correctness, because it had to be. And no one paid any attention to what the hypothesis was, what are we trying to achieve, what questionnaires do we need to do to answer that question. And I think that there's a large number of people around the world now who appreciate how important this is, and I think that we will find that quality of life and patient-reported outcomes will become well, they already are being embedded, but are going to become much more important, and I do see the day when they will be included in regulatory approvals. And I think if, going back to maybe what's spoken about this morning, if people had thought smart about this earlier on with the PARP inhibitors, I think we would have PARP inhibitors in clinical practice today, because they've just based benefits on progression-free survival. Whereas if you ask anyone who's been on a PARP inhibitor and say, how does that compare with chemotherapy, well, there isn't a comparison. So it's a really important question, and I think that there's a lot of people working on that. I think it's going to happen soon. Okay.